Okay, so my brief is to talk about outreach services from a departmental perspective. Firstly, I guess we've got to define what is outreach, and there are a lot of definitions, but points that are in common include descriptions of the target population, who's at risk and what are their needs. And there's at least an assumption that some of those needs can be met on the acute medical or surgical ward, and the response is characterised as multidisciplinary, team-based, providing early intervention and then facilitating transfer if that's appropriate. Now, the first consensus conference on rapid response identified that outreach was a form of rapid response that generally involved smaller teams, which were nursing-based, usually relying on ICU nurses in close collaboration with ICU doctors. And the afferent limb has a much broader scope than a simple paper track and trigger system. It involves proactive rounding, particularly by the nurses. Expert nursing assessments are integral, and nurse practitioners armed with protocols and standing orders allow for some limited interventions in the absence of doctors, and the response is scalable. Well, look, the nature of a healthcare system depends very much on who owns and operates that system. Critical care outreach implies that intensive care is responsible. This carries several implications for ICU resources and governance. But given that in most studies of rapid response, irrespective of the model, 85% plus of patients remain on the ward, it could be argued that the ward services should own and operate the system. But the wards are also constrained by resources, and indeed they struggle perhaps to find the appropriate expertise. Accountability, at least, can be based in the wards, but it's devolved, and it may be more difficult to ensure consistent standards. Now, a fundamental dichotomy is whether the model is nursing or medical, or perhaps some sort of hybrid. In Australia, we have a different approach to the UK. UK has much more nursing outreach. And one of the key differences is that the nursing outreach model tends to require formal funding of the FTE. It has a broader remit, particularly in terms of more longitudinal care for deteriorating patients. The Met in the Australasian context tends to borrow personnel, is largely unfunded, and it's probably no surprise that it has a very narrow task focus. So this is analogous in a way to comparing the regular army versus the SAS. Now, I would argue that to win the fight against patient deterioration, we need both. But there are differences between hospitals based on size and geography, which may impact safety and choice of outreach model. Interestingly, the tertiary and the private hospitals have a high proportion of elective admissions to ICU. So it makes some sense that an outreach model in those facilities might be biased towards perioperative medicine. Whereas the metropolitan and rural regional hospitals have a much higher proportion of unplanned admissions from the ED, in which case the outreach model's got to be able to respond to those unplanned admissions, and the case mix may be different. Well, what is the value of outreach? At least from an ICU perspective, I'm going to be a little bit selfish about this now. Suggestions may include that it prevents ICU admissions, perhaps we allow for earlier intervention and greater quality of care, education and upskilling of the wards, collegiality, and perhaps raising the profile of the intensive care throughout the hospital system. Now, rapid response teams do make a clinical contribution, but they do it either by providing essentially ward-based care that could have been provided by others, or else performing critical care. Now, to the extent that they perform ward-based care, that's largely task substitution. To the extent that they provide critical care outside the confines of an ICU, this is a value add. Now, rapid response systems provide procedures and clinical therapies, teamwork, and skills that are not usually accessible on the wards. And it operates under a governance framework which is intended to improve outcomes for patients. Now, to the extent that that outreach replaces the home team, I would argue that this justifies a reallocation of existing funds. To the extent that it provides critical care outside the confines of the ICU, I think that is a value add and there should be new funding. Now, administrators are acutely aware of compliance, and these standards are about to be updated with some different numbering, but currently outreach cuts across standards 1, 2, 6 and 9. So there's no doubt it's an integral part of our system. But to a modern day hospital administrator, and apologies in advance, Peter, I'm not having a go at you.
Just got a target.
Yep. Exactly. You've got the crosshairs on your forehead. Every safety issue can be regarded as a bit like a nail to be hammered by outreach or the ICU. The trouble with that attitude is that it leads to misuse and overuse of the service. Now, business model canvas is something that's used in business plan writing to articulate key stakeholders, benefits, beneficiaries, finances, all on the same page. It's a way of testing the logic before going further, and I've done this particular slide for outreach as a concept. But what is the logic of outreach from the ICU perspective? And again, perhaps being a bit selfish. Well, does rapid response prevent ICU admission? Maybe. Maybe not. Does critical care outreach prevent readmission of patients to ICU? Maybe. Maybe not. The literature is very divided. There is better evidence that outreach improves nursing satisfaction, so that gets a tick. But whether this translates into reduced turnover of nursing staff is a bit unclear. Now, the concept of outreach can include outpatient follow-up after ICU discharge. And in a UK national survey, it was found that up to 30% of the responding units do run these clinics, usually nurse-led. Now, if they were funded, and that's a big if, the majority that had funding had secured that funding from within the ICU budget. So this is clearly a very important decision for an ICU to make. Now, despite the appealing logic, follow-up programs may not improve quality of life for patients 1 year post-discharge, and therefore they may not be cost-effective. But we should be talking about value with reference to the patient. Now, traditional approaches to measuring value is about relating quality to cost. But talking about adherence to KPIs that are based on processes or best practice doesn't necessarily mean that it was a good outcome. What the patient cares about is survival and the disutility of care. Now, outreach, to the extent that it may improve outcomes, improve survival or reduce morbidity, could be argued as value-based healthcare. Now, there are patient subgroups that I think can benefit from outreach in particular. And many of these patients tend to fall through the cracks of healthcare delivery in hospitals. Good examples will be tracheostomy care patients or complex pain patients. Now, the rapid response team is not a panacea for safeguarding against every bad outcome that occurs in hospitals. And a graded early response, which has an urgent clinical review by the home team or treating doctors and nurses, is absolutely essential, because by the time you get to a MET, hospital mortality, according to ANZICS data, is already 25%. And it remains 15% even once you exclude end of life. So we need to do something earlier. And outreach possibly offers an opportunity here because it is more proactive and tends to result in, involves rounding and perhaps earlier review. Now, a strong evidence base is essential for clinical credibility and for funding. And there is some evidence for critical care outreach, and in particular the nursing model, at least as much as there is for MET. But the literature pertaining to rapid response and outcomes, particularly hospital mortality, is mixed, to say the least. It's labour intensive and the clinical effect is modest. Okay? It may be that a different approach, and perhaps a broader approach like outreach, will secure better outcomes, albeit perhaps with more funding. Now, a potential barrier to outreach, at least involving the nursing model, is possibly the missing member of the team. Why do we tend in this country to have MET and not outreach? Perhaps adoption of the model was based on costs. Perhaps it was to do with leadership, and certainly in the UK, the nursing leadership has been instrumental critical, in fact, in the implementation of the nursing critical care outreach model. Now, it's not all doom and gloom, though, because according to the ANZICS database, 76% of our Met systems are hybrid. They involve nursing and medical staff. So maybe we're already moving towards a multidisciplinary model, although it's by no means universal. Now, Jack Nance talks a lot about, and has written a lot about, teamwork and the interaction between the co-pilot and the pilot in the medical analogy. Now, the trouble with this is that, incidentally, both the pilot and the co-pilot are qualified to fly the plane, which isn't necessarily true in medicine. Sadly, we more often find ourselves late at night in the equivalent of a World War I biplane by ourselves rather than something that looks like the Dreamliner. But outreach, which is multidisciplinary in its format, may be more consistent with crew resource theory. Now, as an ICU director, I've got to make choices where to expend my limited resources. And a comprehensive outreach service based from within intensive care is a significant undertaking. From my perspective, I think it's understandable that directors may hesitate to commit to outreach when the benefits are uncertain and the finances are not locked in. Yet, not surprisingly, hospital administrators and the wards think this is a wonderful idea. Now, the ANZICS Critical Care Resource Survey reveals that most facilities have unfunded medical emergency teams, particularly in the private and the rural sector. The tertiary hospitals fare a little bit better, but even so, designated outreach consultants and registrars are uncommon. Now, critical deterioration, in particular cardiac arrest in the adult setting, is extremely expensive and well and truly exceeds the internationally accepted benchmark for cost effectiveness. And in the paediatric population, it's been estimated that a critical deterioration event costs $100,000 US, and saving just a few of these per year could actually recoup the costs of running a rapid response system. In fact, you can calculate using fiscal modelling and project over the medium term the costs of running an outreach service with 5 to 6 nursing FTE. Okay? This is expensive, okay? $2.7 million as one estimate of a model. But bear in mind the costs of deterioration and sentinel events are also very expensive. Now, there is a relationship, it seems, between call rates and the prevention of in-hospital cardiac arrest. But what is clear is that there's a linear relationship between call rates and costs. Data from Australasia demonstrates that there's a relationship between hospital size and absolute number of rapid response calls. Probably no surprises there. And there may be a tipping point for medium-sized institutions where the frequency of calls becomes overwhelming and justifies an independent, freestanding rapid response team rather than just pulling people out of the ICU who already have other jobs. And it may be that critical care outreach with 5 to 6 nursing FTE becomes economical in these bigger centres. But unfortunately, this is perhaps my most depressing slide, the cost effectiveness and economics of rapid response have been somewhat neglected. If you look at published data on outcomes and call rates and you plot that versus economic modelling of the costs of running the system, what you will see is a divergent pair of curves. So more meds is not necessarily better. In industry, they use something called a marginal cost curve. Now, this is used to evaluate the economies and diseconomies of production. Okay? And again, using published data and a tertiary referral model for a rapid response system, you can see that there comes a point beyond which the number of calls per 1,000 admissions starts to result in higher costs per life saved. And we're already, by the way, well above those call rates. So there are significant opportunity costs associated with outreach. The resources potentially consumed by outreach, by my estimates, would equate to either opening or closing another ICU bed, perhaps 2. Okay. The outreach service beyond that, though, may poach our ICU nurses, and in fact that's happened to us just recently, because at the Mater we've just inaugurated a nursing outreach service, and guess where the nurses came from? The system may generate ICU outliers, which is something that concerns me medico-legally. Nevertheless, outreach may also enhance job satisfaction, foster skills and build relationships. Now, returning to the airline analogy, healthcare is often compared to the airlines. Now, if only it was that simple, because the harmony in the cockpit, which represents business as usual for the pilots, doesn't represent my average day on the job. Will outreach provide clear air for the ICU by avoiding unnecessary referrals? Or will it create more turbulence and pull the pilots out of the cockpit? In conclusion, critical care outreach offers a suite of services. It's a broader remit than just the medical emergency team. And I think it does plug a gap. It's not about just responding to deteriorating patients. It is a patient-centred approach, and it takes us outside our comfort zone. I think one of the things we've got to think about, and in yesterday's session this was also alluded to, is that our core business is being steadily redefined, despite what I think is still a paucity of evidence and a paucity of money. I think outreach has much potential, but to realise that potential we need consistency and we need recognition that a worthwhile innovation requires investment. Thank you.